Hello to all my students. I am Dr. Bansal, Ophthalmology faculty, practicing ophthalmologist and a student. Yes, a student. Once a student, always a student. That is the mantra for the medical life. I keep learning every day. I learned from this INI set question recall that the questions remain the same, the topics remain the same, everybody. Just the way of asking the question differs. I learned that the trend based on the past 3 examinations is that basic questions are being asked. Questions which appeal to your understanding of the subject, to your being in the clinic, yes or no, to you having seen the investigations, to you having seen procedures being done or no. They are not focusing on that elusive piece of information which you may or may not have read. Rather, they are basing themselves on the fundamentals. And that is where we lack somewhere. And that is what we want to learn today as a student, everybody. We are students. We want to keep on learning. We want to utilize these recall sessions because we know that the topics will remain the same. We want to be aware of the high yield topics. We want to be aware of the different ways the questions are being asked. So the trend these days is just to convert the theoretical questions that were asked previously in the past 10 years or so into image-based questions. They remain simple, they remain same, they are just testing your knowledge slightly on a higher level, everybody. So through this recall session, we are going to form our base for the upcoming examinations. So let's start with the questions. So let's start with the first question, guys. Identify the finding given in the image below. So direct image-based question, everybody. You were asked to identify the finding given. As we can see, there is some sort of a ring which is seen. So now all the options, if you see, were mentioning a ring. So based on the options, probably it was difficult if you had never seen the photograph. Otherwise, it was one of the easy questions from ophthalmology. Again, I say all the questions were easy, but this was one of the easiest probably. So what does this look like? Vice ring. Vice ring, if we understand, if we remember, is something seen in the vitreous, if we know it. We may have come across it in RD, retinal detachment. Vossius ring is something to do with pupil, something to do with trauma. Flesher's ring, oh, I don't know. Okay. Kaiser-Flesher ring, I know it is seen on the cornea, copper deposition. Flesher's ring also, if we put a little bit of mind, Kaiser-Flesher, both are sounding similar. Flesher is seen again on the cornea in keratoconus. So if we remember the basic theory of these rings, then we could have solved this image, even if we have never seen this image, everybody. Let's see, everybody. This is my iris, everybody. The pupil has been dilated. This is what, everybody? This is my pupillary margin. So I'm marking it iris, I'm marking it pupillary margin. That means what I can see in the center of the pupil, all this is my lens. So basically the ring which is seen in the photograph is a ring on the lens. So if I see what I see in the photograph, in the image I see a ring of iris pigment. Can I say brown colored ring, pigmented iris tissue on anterior surface of lens? So that's what I'm trying to teach you guys here. That's what I'm trying to explain to you. Even if you have not seen a photograph, please don't worry. Please don't get anoxic. I don't know. Are you getting what I'm trying to say here? So as soon as you write or think about what you see in the image and then you think about the theory, you will be able to solve it, everybody. So this has something to do with iris, this is something to do with lens, this is something to do with pupil, everybody. That means the answer has to be Vossius ring. Even if you have to take a guess, take an educated guess, everybody. That's what I always say. So what is Vossius ring, everybody? I hope we remember. If we don't remember, everybody, what is Vossius ring? So Vossius ring is imprint of a myotic pupil. Yes, on anterior surface of lens, seen as a finding of blunt trauma. As I always explain, it is like stamping, everybody. Yes, when a ball, blunt trauma, everybody, when a ball or a champagne cork hits your eye, there is anteroposterior force. Yes, so all the structures go back posteriorly. When the pupil goes back, it will go back touch the lens with force and come back. So it is like stamping. It goes, stamps and comes back, and that is what Vossius ring is, everybody. I hope we remember other important signs of a case of blunt trauma, everybody, that we should remember, everybody. What are those, everybody? High FEMA, most common sign can be seen. What other important signs come into your mind, everybody? Yes, iridodialysis. Iridodialysis leads to D-shaped pupil. Please remember, very important sign. Then just like iridodialysis, there can be phacodonesis. There can be Vossius ring. We know there can be which shaped cataract? Rosette-shaped cataract. So very simple questions, all of them, very simple images. Blunt trauma or ocular trauma, even though very simple topic, 10-12 questions, but is it very frequently asked in the examination? Now, let's see the images of all the other options given in the question also, everybody. So what is this? This is a Weiss ring. If you see, everybody, this is a view of the fundus, yes? The focus is basically on the vitreous, and in the vitreous, we see a ring kind of structure floating into the vitreous, okay? So this is usually seen in cases of PVD. PVD is posterior vitreous detachment. So when there is full posterior vitreous detachment, there is a solitary piece of debris which is flying into the vitreous, everybody. If there are small pieces of debris, the patient does not encounter any symptomatic problems due to it. But due to this, a solitary ring, everybody. Solitary, I can say ovalish, large ring of debris in vitreous. The patient has complaints of floater. Not always, but yes, the patient will say, when I look like this or this, I always see a circle or kind of a machhar, that is what the patient says, floating in my vision, everybody. And that is indicated of Weiss ring. Whenever you are doing ophthalmoscopy, or if you are doing examination of fundus via 90D examination on slit lamp, as a clinician, as a surgeon, you are able to see that. This holds no clinical significance per se, unless associated with RD or unless you see some other signs of retinal detachment, mainly rhigmatogenous retinal detachment, everybody. Done? Moving on. This is, all of us know, everybody, we can see the cornea. On the cornea, we can see a golden brown ring. I hope we can see a golden brown ring on the cornea peripherally due to deposition of copper. In which layer of the cornea, everybody? Descemet's membrane. Yes, so this is what, everybody? Kayser-Fleischer ring. All of us know Kayser-Fleischer ring. Some salient points about Kayser-Fleischer ring. We all know that it is seen in cases of Wilson's disease. Yes, but Wilson's disease, 100% cases if it is neurological involvement due to deposition of copper in the basal ganglia, but only 50% of cases in hepatic disease. So it is universal in neurological neurological Wilson manifestations, not universal in hepatic, everybody. But this is not pathognomic of Wilson's. This can also be seen in cholestatic disorders like primary biliary cholangitis. Okay. What is the treatment? We need to have chelating agents, everybody. So the chelating agents are penicillamine or tri-anti, which are given orally, but they have to be given lifelong. They have to be given lifelong because Kayser-Fleischer ring will disappear in about 3 to 5 years on treatment with these chelating agents. But if we stop this, then they will reappear. So either you have to continue them lifelong, or you have to add zinc, which acts as a maintenance therapy, because zinc does not allow the copper to get absorbed in the body. So the chances of forming of the golden brown ring, the Kayser-Fleischer ring itself reduce. Okay, everybody. So some salient features about KF ring, please do remember them. Very, very important question about Wilson's disease. Now, this is Fleischer's ring. So as I said, Fleischer's ring is something which is seen in keratoconus. Point number one, this is a confounding term because whenever we hear Fleischer's, we straight away think of Kayser-Fleischer and Wilson's. But we have to focus on the word Kayser. Kayser is important, right? So what is Fleischer's ring? Fleischer's ring is the ring of iron, or to be more precise, hemosiderin deposition. That was copper. This is iron or hemosiderin deposition in keratoconus at the base of cone, not at the apex of cone, at the base of cone, everybody. Okay, slightly difficult to see. Image may be asked, less chances. But if we try to see, everybody, see here, first of all, see this. This is a slit of the cornea. So if you see the slit of the cornea, if you try to understand, this is the inner layer which we can see, which I am marking right now, endothelium. This is the anterior layer which I can see, this is the epithelium. In the center, if you see, it is forming a slight cone kind of stuff, guys. Yes. So this is how an examiner, when he is looking on a slit lamp, is trying to make out whether the thickness is constant or is it forming a slight cone, everybody. So if you see here specifically, I am marking it again. If you see here, it is forming a slight cone, everybody. Again, clearing it for you. Again and again pointing it out, everybody. Yes. Now, if you cannot make it, it's all right, guys. As I said, anyways, it is tough. What other thing I am trying to see is, can you see this faint dark brownish ring, everybody, marked by these yellow arrows, everybody? Again, see, everybody, this line, everybody, this ring, everybody. This is the base of the cone, and this is what Flesher's ring looks like. Or if you see the other photograph here, also you can see where my pointer is moving right now, everybody. You can see a deposition, everybody, at the base. And this is what a Flesher's ring is. It is not seen in all cases of keratoconus, but it is pathognomic. No, Vogg's striae are pathognomic. Please remember again, what is pathognomic of keratoconus is Vogg's striae. Okay, not Kayser-Flesher ring. And it is slightly difficult to see, everybody. Just please remember these points about all these rings, so that if tomorrow any of the other images is given, you are able to solve them. So that's your first question, which was asked in the INI set November. It was an easy question based on the image it was given. Okay, now moving on to the next question. Again, an easy question. Again, direct IBQ image based question. No bull here or there, everybody. Simple. Identify the chart given below. Whether you have seen it or not, whether you can answer it or not. All the options, actually based on the options, it was an easy question. So what we see, everybody, is we see a chart with some squares but with concave lines, everybody. So the confusion could have been there if the options were slightly differently framed. If the option had, let's say I put an option E, if the option had Amsler's grid, then probably identification may have been difficult, because Amsler's grid also has some squares. What does an Amsler's grid look like, right, guys? Amsler's grid consists of straight line squares, not of curved or concave line squares. So that is where you may have got some difficulty. But otherwise, Snellen's chart everybody has seen, so I don't think anybody would have marked Snellen's chart. ETDRS chart, if you have ever read optics, you know it is also a chart for far vision, which looks like Snellen's charts in some regards. That could not have been. Pelly-Robson chart is a chart for, again, some letters having contrast sensitivity testing, everybody. So if you had read optics, you would know this, and that is why you could easily rule out and mark it as a Hess chart. If you don't, then see it here. Hess chart is a test for diplopia. Hess chart is a test for diplopia. Okay. The patient is asked to close each eye one by one, and then, asked to mark the point based on the actions of each of the muscles in whichever direction he can see till which point. Then based on the comparison with the normal excursion of movement or the eye in a particular point, you are able to find out which direction the patient may be having diplopia in, and then based on that which muscle may be paralyzed. So basically a test to find out diplopia in cases of paralytic squint, everybody. So we call it test for diplopia. Hess chart. The chart is given in front of you, printed on a piece of paper of red color. Now, if you don't know what an ETDRS chart looks like, this is what an ETDRS chart looks like. Consists of letters, 5 letters in each row. That is the difference, everybody, if you will note from Snellen's chart. Snellen's chart, the number of letters keep on increasing. Here, 5 letters in each row, but the size is decreasing. In the Indian medical system, we don't use ETDRS chart too much to measure the far distance. This is called logmar chart also, everybody. So the vision gets recorded as 0.1, 0.2, usually used in the United States medical system much more than the Indian or the British medical system, everybody. Moving on, everybody. Which chart is this, everybody? I hope this should be pretty clear. The topmost letters are the darkest, and as you move down, the contrast decreases, everybody. So this is your Pelly-Robson chart, everybody, and this chart is for testing contrast sensitivity. Okay. And lastly, good old Snellen's chart, everybody. I hope all of us have seen the Snellen's chart. There should be no confusion, everybody. The size of letter keeps on decreasing. Size of letters keeps on decreasing. but the number of letters in each subsequent row keep on increasing, everybody. The topmost row has to be led from a distance of 60 meter, 36, 24, 18, 12, 9, and the last row 6. This is done from a distance of 6 meters. The least possible vision recordable is known as, or is 1 by 60, not known as, everybody. Mathematically, it is 1 by 60. What a patient can see from 1 meter, a normal person can see from a distance of 60 meters. Right, guys? Moving on to the next question. What is the most common eye manifestation of COVID-19? Obviously, sooner or later, a question on COVID-19 was bound to come. Okay. So, there is no conclusive data as such, everybody. Large-scale studies have not been done. Meta-analysis has not been done. But based on a lot of studies in a lot of areas, in a lot of countries, everybody, the fun thing that has come out is that the most common manifestation as far as a sign is concerned is congestion. Okay, everybody, congestion or injection, whatever you want to call it, basically redness. In patients who are having COVID-19, either as the first sign or symptom, or everybody after the systemic signs, usually what eyes being seen or complained about is of congestion, everybody. Along with that, patients complain of foreign body sensation, patients complain of watering, irritation, and all such stuff, everybody. Basically indicating that ocular surface disorder, congestion, foreign body sensation points towards conjunctivitis. And through examinations, it has been found out that just like other viral causes of conjunctivitis, COVID-19, which is also a virus, causes follicular conjunctivitis. Yes, if we remember, everybody, I hope, papilla, follicles, watery discharge, mucopurulent discharge. Papilla with watery discharge is allergic conjunctivitis. Papilla with mucopurulent discharge is bacterial conjunctivitis. Follicle with watery discharge is viral conjunctivitis. And here comes chlamydial follicle with mucopurulent. So follicles basically are seen in viral conjunctivitis, and that is what is the answer. Has no other manifestation in the eye been seen in cases of COVID-19? No, everything has been seen. Yes, a lot of manifestations have been seen. Pseudomembranous conjunctivitis has also been seen. But in a case series of 12 patients, 2 patients having pseudomembranous conjunctivitis, retinal vein thrombosis has been seen, but in a solitary patient in some country. So these findings have been seen in solitary patients. So they are not good enough for us to recognize as signs of COVID as yet, unless some more series or some more reports of such patients come out, everybody. So for now, for recognizing COVID-19, please remember the only ocular manifestation to keep in mind is congestion, foreign body sensation, watering, irritation, signs and symptoms indicative of follicular conjunctivitis. Yes. Can it be transmitted? There is no conclusive answer, but yes, it can be transmitted through ocular secretions. That is what the consensus is. So, as a clinician, we have to be careful about this, everybody. Okay, done. Moving on. Okay, again an image-based question, slightly difficult image-based question. A lot of students were divided on the answer to it. Though if this was the image or such an image was given, the answer should have been clear, everybody. Identify the step which is given in the image. So first of all, we are talking about what, everybody? This is a cataract surgery being done, everybody. If you don't know this is a cataract surgery being done, read the options and you would know they are asking about cataract surgery, everybody. Now they are trying to ask you, which step is this? So, do we know the answer? I hope we know the answer is capsulorhexis. But if we have any confusion, everybody, let's see the photographs of other steps sequentially. So, it is important to have a sequential view in mind. First of all, what do we do, everybody? First of all, we create a side port, everybody. Okay. So, you see a small blade here. This is called the MVR blade, everybody. MVR blade. Or it could be done using a 15-degree blade. So 15-degree blade basically means the angle is at 15 degree. Okay, so this is a 15-degree blade mounted on a handle, obviously, right? So either using a 15-degree blade or an MVR blade as shown in the image. First of all, we create a side port. Through the side port, do we do what, everybody? Through the side port, we stain the anterior capsule This is a surgeon's preference, not required in all cases, as I always say. If we stain it, we stain it through which dye? We stain it through trypan blue dye. Okay. Now after staining, why are we staining it? We are staining it to create a window to go inside the lens, everybody. So create a window in the anterior capsule. When we create in the window in the anterior capsule, it is known as capsulorhexis, everybody. So CCC, continuous curvilinear capsulorhexis. Okay, everybody, CCC, continuous curvilinear capsulorhexis. This can be created using what is shown in the photograph. This is known as Utrata forceps. Again, these are surgeon's choice, everybody, which instrument the surgeon wants to use for which step, everybody. There is no hard and fast rule. Yes. So as you can see, through the incision, everybody, the Utrata forceps has gone inside the anterior chamber. It is holding the anterior capsule and a circular motion has been done to create a rhexis. There is no staining here, everybody. So this surgeon does not stain or did not stain, and without that, based on the fundal glow, everybody. So you can see a yellowish brown or a reddish glow, orangish glow coming. That is from the fundus. So against the fundal glow, without staining the capsule, also you can create a capsulorhexis. Okay. So I hope we are pretty clear about this. But this is not the only instrument, everybody, based on which you can recognize it. The other instrument is this, everybody. This instrument, this is a bent 26 gauge needle and we call it a cystitome. So I personally prefer making an capsulorhexis or a CCC using a cystitome. So as I say, it's a surgeon's choice. So it's a bent 26 gauge needle. We have gone inside, we have created a flap. I hope you can see. Now here is the cut, here is the flap, and now this flap will be pulled in this direction and it will be extended. As you can see, I've started pulling it, and now slowly we will be able to complete it, everybody. I hope you can see at least this much, that this is the flap, everybody, and this is the area where my capsulorhexis has started to form, and now it has to be completed in a circular motion. Okay, everybody. I hope there is no confusion regarding the photograph. Okay. Now, moving on to the next step, everybody. After we have done this, now we create the main port, everybody. So you will see a larger blade being used. So this is done using a keratome. Keratome can be 2.2 mm to 3.2 mm in size. Generally these days, with advancements, with good machines, 2.2 mm keratome is being used, everybody. Okay. Now through this main incision, what do we do? The first thing we do is hydrodissection. So now as you can see, in this case, it is a stained capsule. This is the CCC which has been created. Okay. Now we have taken a syringe below the anterior capsule, everybody. So syringe or cannula, rather I will say, cannula below the margin of anterior capsule, and we are pushing fluid, everybody, injecting fluid. Okay. So what are we doing, everybody? We are doing hydrodissection. What are we trying to do? Because we do not want to remove the capsule, we are trying to separate or dissect, everybody, the cortex from capsule, so that when we try to remove the cortex, the capsule does not get pulled out along with it, everybody. We need a bag to implant the intraocular lens. Yes. Now, after this, what we will do, everybody? After we have separated this, we will try to remove the nucleus by phacoemulsification. So this is the phaco probe, everybody. Phaco probe. Phaco probe has a piezoelectric crystal. What does the piezoelectric crystal do? Piezoelectric crystal converts ultrasonic energy into mechanical to and fro motion, which help in nuclear fragmentation. So first we need to break down the nucleus into small pieces, and then we will irrigate and aspirate everybody. After we have irrigated and aspirated, we are left with an empty bag. After we are left with an empty bag, we implant an IOL. So as you can see, this is an injector and this is the IOL getting injected. You can see the haptic here, you can see the optic. It will slightly slowly unfold and you will be able to implant it in the bag. IOL implantation. Okay guys, done. So I have revised a lot of steps of the surgery with you with the photographs. We have seen them, we have revised them in the videos everywhere. Everybody, if you had any confusion, I hope you are pretty clear about this, that this image is of capsulorhexis. Okay. Moving on to the next question, everybody. A patient is a known case of angle closure glaucoma. Okay, so the diagnosis is already given in the question. He is going to be prescribed antidepressants. Now, why does the question become important? Because we know as a group of drug, antidepressants are a cause of precipitation of angle closure glaucoma, right? Which of the following drugs should not be used? Now, all these are antidepressants, everybody, we know. Out of this, which has the most likelihood of precipitating? Sertraline is an SSRI, though associated with the precipitation, usually does not cause. Fluvoxamine, again an SSRI, can be associated. Yes, I'm not doubting it. Yes, it can be the answer. Mirtazapine is a antidepressant which is not associated at all with angle closure glaucoma. But amitriptyline, which is a tricyclic antidepressant, everybody, this is highly associated, and that is why this is the most likely answer. Along with the fact amitriptyline has anticholinergic action, everybody, and this anticholinergic action leads to mydriasis or mydriasis and thus the precipitation of angle closure glaucoma. Okay, we know this, we have studied this in pharmacology. The only confusion, if possible, could have been between option C and D. Let's see a complete list of drugs which precipitate angle closure glaucoma and their mechanisms, everybody. Okay, so adrenergic agonist, everybody, like phenylephrine, ephedrine, or non-catecholamine adrenergic agonists like nafazoline and salbutamol. All of these will cause pupillary block, everybody, dilatation, pupillary block. Anticholinergics, as we were just discussing, anticholinergics like tropicamide, ipratropium, promethazine, botulinum toxin, all of these again cause pupillary block precipitation leading to precipitation of angle closure glaucoma. Pilocarpine is a miotic, it's a cholinergic. So we know it will not cause the same thing as all of the mydriatic agents, yes, but it causes the precipitation via forward displacement of the lens iris diaphragm. So as a whole, the lens iris displaces forward. When it displaces forward, it further narrows the already at risk or closed angle, everybody. Yes, we need to open the angle, not close the angle through forward displacement. Okay, so please remember that pilocarpine, even though it is a miotic, can still lead to precipitation of angle closure glaucoma. Now, medications with anticholinergic side effects. This is where our question was based, everybody. Tricyclic antidepressants. Here imipramine is given. We have just discussed amitriptyline. Fluvoxetine SSRI, as I told you, it can also cause it, but more likely, yes. Then sulfa-based agents like topiramate. Questions have been asked previously. What is the mechanism? Ciliocoroidal effusion leading to forward displacement of lens iris diaphragm. And similarly, acetazolamide. Acetazolamide, even though it is a treatment, everybody, for emergency cases of reduction of IOP, but understand, it is reduction of IOP. We are not actually treating angle closure glaucoma, so you don't give it, keep on giving it, everybody. Yes, so it is an emergency drug. If you give acetazolamide oral 250 milligram, 2 tablets stat, or for 2 through 3 days, it is not going to precipitate the glaucoma. It is going to reduce the IOP, which is the need of our in emergency acute angle closure glaucoma cases. So please don't get confused as far as acetazolamide is concerned. Yes, it can also precipitate angle closure glaucoma. Am I absolutely clear? This is a comprehensive list. Please remember, please understand, and please answer the questions correctly here, everybody. Moving on, everybody. Okay, So I know, again I will say again and again, I keep on saying easy questions, but actually these are easy questions. Yes, a patient is not able to see the lateral fields. He was having a mild headache for few weeks and now presented to the clinic. Visual field examination shows the following finding. See, if the image was not given, then the understanding of English, understanding of what not able to see the lateral fields may have differed from student to student. Yes. But because the image is clearly given, you don't even need to read the question, guys. You just need to see the photograph and answer. So what is this, everybody? We know this is the temporal side. We know this is the temporal side. So which side is lost in both the eyes, everybody? In both the eyes, temporal side is lost. That means it is a straightforward photograph of bitemporal hemianopia. Again, there should have been no confusion. A lot of students came back to us with the questions saying, sir, it was something written about both the lateral fields or one lateral field. But if the image was given, everybody, then there should not have been a confusion. Some students came back and told me, sir, that the image was not given. If the image was not given, then also read the question. A patient is not able to see the lateral fields, everybody. Yes. Lateral means what, everybody? Lateral means this. The patient is not able to see lateral fields. There is no visual field defect in which a patient is not able to see one of the lateral fields, everybody. Yes. So that should not have been the answer. Lateral field means both lateral fields, both temporal sides, everybody. Yes. The answer is as clear as daylight. Optic chiasma. All the other options given in the question, occipital lobe, optic tract and optic radiations, they would have caused what, everybody? Option A, B and C would, option A, B and D would have caused contralateral homonymous hemianopia, which would not have been described by the patient in these terms. The patients would have described that I cannot see towards the same side from both the eyes. I cannot see towards the right side from both the eyes, or I cannot see towards the left side from both the eyes. That would have been the language by the patient. Yes? Yeah. Moving on to the last question that was asked as far as ophthalmology is concerned in INA set. Again, I am saying easy question. So as I said in the beginning, this is probably the way the examination will proceed. They are going to ask you basic questions which test your knowledge rather than asking you difficult and, out of the world questions, right? What is the most common mode of spread of retinoblastoma? This question assumes importance because a lot of answers are given by students as neural via optic nerve. But please understand, neural via optic nerve is not a mode of spread. Mode of spread can be through blood, hematogenous, through lymphatic, or directly, everybody. So the answer here is direct. Now, direct spread can take place directly through the sclera or through the optic nerve. Which is the most common direct route of spread? Then the answer is optic nerve. But as long as direct is given in the option, you cannot answer optic nerve. Again and again in my lecture, everywhere I have said this, but students keep on making this mistake, and that is why such a simple question keeps on getting repeated, everybody. If direct is given in the option, that is the number one answer. Direct spread can occur through a lot of structures. Direct means through the tissue itself. So optic nerve is a part of the eye. Through the tissue it is swelling, but it is a direct route of spread, everybody. Emphasizing it more than is required, but I hope you do get it, everybody. That's it about the INI set recall, everybody. As you would have seen, again, I need you to focus on the basics, everybody. We do not want to go into the unknowns, everybody. If you do the known, then you are good enough. Unknowns will not be too much anyways, everybody. So don't run after that elusive piece of information, everybody. Please focus on what you can do. Please focus on doing it again and again, revising it again and again. Please focus on the high yields, everybody. Ophthalmology is a high yield altogether as a subject, everybody. So please do focus on ophthalmology. Thank you, guys. Bye-bye.